Hi, and welcome to session 31 of the Falcon Anatomy Review Online. Now we're going to be discussing the pelvic spaces and walls. The pelvis in general is not a tricky space, it's just a hard to understand three-dimensional space. So it's really important in my mind to set up the spaces so that you can break the information down into those spaces. And this will become very handy when you're dealing with questions because you'll automatically know which region you're in and what is and is not in play in those particular regions. We'll start with the orientation of the pelvis, and you can see here that the ASIS and the pubic tubercle with that plane of the inguinal ligament is in a vertical plane. Also, we've already seen the greater sciatic foramen and lesser sciatic foramen with the ligaments that form it, the sacrotuberous and sacrospinous. Acetabulum has been demarcated, and then of course there's the obturator fascia, which would form the obturator foramen. If we look at the joints, ligaments, and foramina, the sacroiliac joint is going to be the joint between the axial skeleton and the pelvic girdle. It actually transfers weight from the upper body and the thorax and abdomen through and into the lower extremity, and it has very strong fibrous ligaments that will anchor it on both sides. It has very good congruity, one of the best congruous joints there is, but that also means that very small movements can cause clinical significant problems. The pubic symphysis will be reinforced in the midline by fibrocartilaginous disc, and it will be reinforced by superior, anterior, and arcuate pubic ligaments. It's relatively immobile except in pregnancy when the hormones will cause it to become loose and lax. Oftentimes by examining a pelvis, the pubic symphysis after pregnancy, at least in natural childbirth, will not come back to the exact same position it was prior, and there will be a malalignment at times, which will give an indication of whether or not somebody's had children. So here you can see some of the ligaments that we've discussed from a posterior and anterior view. A great look at the sacrospinous from the anterior view and the sacrotuberous ligament from the posterior view. This image shows a wind-blown pelvic fracture, which is a result of lateral compression against the iliac crests. It will cause a gaping injury, which you can see quite clearly on the left side where the iliac connects to the sacrum. Remember, the pelvic fractures will sometimes include problems with the bladder. It can damage reproductive organs, and it can cause fatal hemorrhaging from all of the large vessels in this area. There are also iatrogenic causes of pelvic problems, which would include screws that need to be carefully placed because they can pierce through major vessels. And there's going to be skeletally immature people which will have avulsion fractures at various sites of muscle attachment, as we've discussed before, either from the ASIS with things like the sartorius or off the ischial tuberosity with the hamstrings. Here's an avulsion type issue, which is a stamp abrasion, and you can see that it matches up with the tire. This person was fatally wounded when they were ran over by a heavy vehicle. We've already discussed the abdominal pelvic cavity. Now we're going posteriorly and inferiorly to look more at the pelvic diaphragm and not so much the thoracic diaphragm. Across the iliac crest, there's going to be a division plane where you get into the false pelvis, and then across the pelvic aperture, or the inlet, will be the dividing line for the true pelvic space. But to be in the true pelvis, you must be above the pelvic diaphragm and below the pelvic inlet, whereas in the false pelvis, you have to be above the pelvic inlet and below the iliac crest. This divides the area into a greater or false pelvis and a lesser true pelvis. On the inferior surface of the pelvic diaphragm, there's going to be a diamond-shaped pelvic outlet, and that's going to be bound by some bone, the coccyx, and the ischial pubic rami, as well as some soft tissues, the sacrotuberous ligament. Let's talk about the spaces of the pelvis. We have a rule of twos in the spaces of the pelvis. There are two ligaments that create two specific spaces, and they're going to be the sacrotuberous ligament, which will form the greater sciatic foramina, with the sacrospinous ligament, and there's going to be the lesser sciatic foramina. Then we have two muscles that make the wall of the pelvis, which will be the lateral and posterior wall, one from each of those spaces. First, there's the piriformis that will run through the greater sciatic foramen, and there's the obturator internus, which will exit through the lesser sciatic foramen. Those will form the lateral walls of the pelvis. And then there are two diaphragms. Actually, one is a diaphragm and one is now called a membrane. There is the perineal membrane, which used to be called the urogenital diaphragm, and there's also the pelvic diaphragm, which is actually a true diaphragm. And they will form two triangles in the perineum. The perineum is diamond-shaped, so there's a triangular anal triangle posteriorly, and at 90 degrees to this, there's a urogenital triangle which hangs inferiorly. The urogenital triangle is then divided into two pouches. There's a deep pouch, which is deep to the perineal membrane, and there is a superficial pouch, which is everything of the external genitalia that will be outside the superficial or the perineal membrane. So let's take a look at these pelvic spaces using this diagram. First of all, we have the pelvic inlet or brim, and above the pelvic brim we will have false pelvis. Below the pelvic brim but above the pelvic diaphragm, shown in this dotted line, there will be a true pelvis. If you're outside the perineum, you're going to have this perineum which is diamond-shaped with a posterior triangle and an anterior triangle. The anterior triangle will be the urogenital one, and the posterior triangle will be the anal one. If you're above the urogenital triangle and still with the outside portion of the pelvic diaphragm, you're in the deep pouch. If you're outside of that area, you're in the superficial pouch. So here we can see the two muscles put into place and the diaphragm. On the right, you see the piriformis heading through the greater sciatic foramen and the obturator internus heading through the lesser sciatic foramen. On the left, you see the pelvic floor muscles, which are composed of a levator ani and a coccygeus muscle. And all together, they make the pelvic diaphragm. So we now have lateral walls and a floor to the pelvis. The floor will support the pelvic viscera, and the lateral walls will help fill in some of those holes and actually be conduit pipelines for either vasculature or structures that are needing to get in and out of the pelvis. From the posterior aspect, you can see how the ischial spine will serve as an attachment for the coccygeus muscle. You have the piriformis above that and the obturator internus below that. Notice how the obturator internus turns a 90-degree corner as it goes through the lesser sciatic foramen and reaches for the greater trochanter. The pelvic diaphragm is going to be that cone shape of muscle that's coming down, and then it has the external anal sphincter around the distal edge of that, where it then becomes the anus. There's a nerve that exits below piriformis, and that's the pudendal nerve. It crosses over the ischial spine as it heads between the obturator internus and the pelvic diaphragm. Notice how it's giving off branches that we'll talk about in a little bit later to the external anal sphincter. Now we'll look at the different ways of subdividing the pelvic floor muscles. Usually when there's more than one way of dividing something, it's simply because someone didn't feel happy enough with the simple way of doing it. So, all of the things that we're looking at here coming off the tendinous arch will be attachment and pull points for the pelvic diaphragm, which again is just a bilaterally constructed bowl of muscle that has a little hiatus anteriorly called the urogenital hiatus for all your junk to protrude through. and then you're going to have some muscular components to it. Altogether, you can call those muscular components of that pelvic bowl the pelvic diaphragm. Or you can break it up into its subcomponents. There's 3 to 4 subcomponents, depending on how you want to do it, or there can be 2 subcomponents. The 3 major subcomponents would be a component off of each portion of the os coxae, one off the pubis, pubococcygeus, one off the ilium, iliococcygeus, and one of the ischium, which would be ischiococcygeus. And the ischiococcygeus can then be dropped as far as the ischioport and just called coccygeus. If you combine the 2 components of pubococcygeus and iliococcygeus, those are going to lift the pelvic contents, and those are called levator ani. So again, 3 different ways of looking at it. Altogether, pelvic diaphragm, subcomponents, pubo, ilio, and ischiococcygeus, or the in-between version, which would be the levator ani and the coccygeus. They fuse together with an anal coccygeal raphe or raphe, and then there's another subcomponent of the pubococcygeus that functions independently, which would be the puborectal sling, and that will come around the rectum itself as it goes towards that midline hole that we can see, which would be the anal aperture. The urogenital hiatus is going to have 2 holes if it's female, 1 hole for the urethra if it's male. And this is just words discussing the different ways of breaking down the pelvic diaphragm. In a lateral view of the pelvic cavity, in this picture here, we can see the lateral wall muscles, the obturator internus, and then the posterior wall, which would be the piriformis, and then we can see the tendinous arch, which its insertion points off of it will form into the pelvic diaphragm. What we want to add in this lateral view is that the perineal membrane is sitting across between the 2 subpubic arch, or the inferior and ischiopubic rami, and that's where that urogenital hiatus sits, which will allow, in this case, since this is a female, the urethra and the vaginal tract to pass through from the pelvic cavity out through the deep pouch and into the superficial pouch, which is where the external genitalia will sit. Here you can see a rendering, or an artistic rendering, of the 2 perineal membranes, and you can get an appreciation for the things that are in the deep pouch and the things that are in the superficial pouch. What you can see is that there's 2 openings in the female, the vaginal and the urethral opening, and only the urethral opening in the male. Each of them has an external urethral sphincter, which is voluntary skeletal muscle around the urethra, which will help compress it. The female has a compressor vaginalis that will wrap around, and this is skeletal muscle as well, giving them some voluntary control over the distal portions of the vaginal tract. In the male, there's the external urethral sphincter, and there's just really this one muscle, although there would be some little fibers that would wrap around over the prostate, which would be equivalent to those compressor vaginalis muscles that you can see in the female. Here's what it looks like sitting under the subpubic arch. What I want you to notice here is that there are some glands in this male perineal deep pouch, because there's going to be the pre-ejaculate released from these Cowper's glands. The other interesting thing is that there's a vein that drops directly over top of this perineal membrane right back into the pelvic plexus of veins, and this is going to be a potential passageway for the passage of cancers as they drop right back in from the penis towards the pelvis. So these cut down perineal membranes can now see the bulbourethral glands, or Cowper's glands, which will produce the pre-ejaculate. You can also see the entrance of the vasculature and the nerves. The vessels will come from the internal pudendal artery, and the nerve will be the pudendal nerve, and it will supply the muscles here, and also the muscle that will sit on top of this, which will be the erectile tissue muscles. They will become the dorsal artery nerve of the penis or clitoris in male and female after they've supplied the structures within the perineal membrane's deep and superficial pouch. So what are some of the differences between the male and female bony pelvis? Well, this is just a chart to show some of the differences. The false pelvis in a male is deeper. The pelvic inlet is narrow and heart-shaped. The pelvic cavity is more tapered and cone-shaped, and the pelvic outlet is smaller. The female, of course, would be the opposite of all of those and would be more well suited for carrying a pregnancy and then passing that pregnancy through the outlet. Therefore, the subpubic angle is smaller in males, and the sacrum is more curved. Also, the anterior pelvic wall is longer in a male. Now, the overall size of a male pelvis is actually bigger than that of a female, but the proportionate size would be the female's being bigger based on body size itself. Here's some pelvic measurements that are going to be important gynecologically. There's going to be some dimensions of the pelvic inlet and outlet that are of obstetrical significance, and any pelvic deformities or variations may make it difficult for parturition, and they may opt for having a surgical team on hand, or they may go straight to the cesarean section. So some of the measurements of significance are going to be the true conjugate, which is a diameter from the anterior-posterior measurement between the sacral promontory and the pubic symphysis. A diagonal conjugate, which will measure the distance from the sacral promontory to the inferior border of the symphysis. And then the transverse diameter, which will be the greatest distance between the opposite sides of the inlet. The oblique diameter, which will be between the sacroiliac joint and one side of the iliopubic eminence. And then the distance between the ischial spines, which is easily palpated during exam. Some other measurements of the pelvic outlet are going to be the anterior-posterior diameter, which will be between the tip of the coccyx and the inferior border of the symphysis, and then the transverse diameter, which will be between the medial surface of an ischial tuberosity and the smallest diameter of the pelvic outlet. And this is of particular importance because if baby's head will not fit through the transverse diameter, there's going to be some issues that need to be taken care of, and they need to decide of whether or not they're going to have a natural childbirth or not. Here's a graphic way of looking at some of the differences between male and female pelvis. That concludes our segment on the pelvic walls and the pelvic spaces. The next section will look at pelvic nerves and vessels.